behalf of ESOT, myself, Sarah Hosgood and Gabriel Oniscu, I'd like to welcome everyone to this webinar on establishing a normothermic regional perfusion programme. So this webinar is part of the Machine Perfusion track. And I'd really like to thank all our sponsors for this webinar. So we've got a really very exciting programme which is dedicated to NRP, with talks from an excellent panel of experts, and these include ethical and practical considerations, organ utilisation and outcome, technical approaches and technical detail with a practical demonstration. We also have a session on troubleshooting and a case-based discussion. I'd just like to remind everyone to place any questions in the Q&A rather than the chat. And if time permits, we'll have a short Q&A session before the break after the talks for the first part, and then we'll have a Q&A session at the end. So I'll just hand over to Gabby to introduce our first speaker.
Thank you, Sarah, and welcome to this webinar. It is my great pleasure to introduce the first speaker who is going to set the scene on the ethical and practical consideration of NRP. Dr. Corinne Antoine is a nephrologist with a postgraduate diploma in public health and biostatistics. She works part-time for Agence de Biomédecine, who's really in charge of the uncontrolled and controlled DCD donation in France, and has been instrumental in setting up the NRP program there. So, Corinne, over to you, and look forward to hearing your thoughts on how to deal with the ethical issues in NRP.
Good afternoon, everyone. Perhaps we can start now the PowerPoint. Hello, everyone. First of all, I would like to thank ESOT for inviting me to this very interesting webinar. I'm pleased to share with you some challenging issues and the ethical and practical consideration about NRP. I have nothing to declare. First of all, what we are talking about. Very briefly, I will describe NRP to you. NRP needs to use an extracorporeal membranous oxygenation device, so with a centrifugal pump, a membrane oxygenator, in normothermic condition. That means a temperature more than 20 degrees, maintained thanks to an heat exchanger. Before to start NRP, you need, first, to cannulate the femoral vessels. Secondly, to prevent brain reperfusion during NRP, the descending thoracic aorta should be occluded above the diaphragm using a vascular clamp after supra-rapid sternal aportomy, or using a natural Milan balloon. Only after the not-touch period of the death declaration, the balloon is inflated or the aorta clamped, directing oxygenated blood to those organs to be recovered for transplantation, and more crucially, isolating brain circulation. Thirdly, to minimize warm ischemic time of lungs, reintubation and lung reimplantation should be performed. Today, NRP is not an exception anymore and is frequently used by mostly European countries, and it is illustrated by this updated overview from Lomero and others in context of uncontrolled DCD program. And just to illustrate it, the pinpoints representing the countries using NRP today. And for example, in France, Italy, and Norway, NRP use is mandatory in DCD liver recovery. NRP is a new technique, highlighting some significant new ethical challenges. Why? Because NRP implies a re-establishment of the circulation after the determination of death. The most critical risk is the possibility that circulation to the brain is inadvertently restored during NRP, which would negate the diagnostic of death by secondary criteria. By this way, it could compromise a very important axiom of the death tunnel rule, as you know, that vital organs should be removed from person only once they are dead. Secondly, there is a question of the lung reinfection performed during CDCD lung recovery that could be associated with a resumption of cardiac activity. And thirdly, NRP transforms a rapid recovery procedure into an elective procedure, and by this way, it implies antemortem interventions which could be considered as alterations in routine end-of-life practices. So you have to understand, we have to balance these ethical challenges with the benefit demonstrated by NRP, with a strong rationale to perfuse the CD organ that I will not detail now because it will be done at the next talk. Brain reperfusion, is it a theoretical or a risk? There are two main hypotheses that could be explained brain reperfusion despite descending aorta occlusion. The first one, brain reperfusion could be restored due to collateral circulations. In this very nice paper, Manara and others propose refinements to current protocols to document the risk of reperfusion and to monitor and exclude brain reperfusion during NRP. You are here the figure A, and this figure illustrates the different collateral circulations that could theoretically restore flow to the brain, mainly from intercostal arteries. To answer the questions, what additional reassurance can we provide that brain perfusion is not restored during NRP? Manara and others suggest to insert a cannula in the ascending aorta to measure the pressure and leave it open to atmosphere before starting abdominal NRP. The primary purpose of this cannula is to monitor the adequate occlusion of the descending aorta or to detect and divert any potential collateral flow to the brain. This approach has been used in 12 abdominal NRP organ recoveries in the UK. Descending aorta occlusion was performed by clamp or by intraluminal balloon, and when measured, there was no proximal aortic flow in any patients, and there was a maximal pressure of 0 to 3 mmHg in the ascending aorta cannula. So the authors conclude to the absence of pressure or the absence of flow gradient for brain perfusion, supporting their conclusions that an adequately occluded descending aorta prevents collateral flow to the spinal and vertebral arteries or to the carotid circulation. So brain reperfusion through potential collateral circulations is a theoretical and not a real risk. The second possibility, brain reperfusion could be restored due to malfunction, inadequate filling or misplacement of the aortic occlusion balloon. To evaluate this risk and to provide additional reassurance, Perez-Villares and others described and validated a specific methodology to ensure an appropriate blocking of the thoracic aorta in 4 Spanish centers in 78 CDCD donors. Cannulation of femoral vessels was performed prior to the WST. The deflated aortic balloon is introduced through the contralateral femoral artery. Pressures from the 2 arterial lines, one from the left radial artery and the other from the femoral arterial cannulae, were monitored throughout the procedure. Before WST, the balloon was filled for just 4 seconds, and the disappearance of the pressure from arterial femoral cannulae and from the left radial artery was monitored. After an untouched period of 5 minutes, death is declared when there was no pulsative waveform in both arterial lines, femoral and radial. Only in 4 cases, just after NRP, continuous arterial pressure from the left radial artery was measured, leading immediately to correct positioning or filling of the balloon and to restart the NRP after a second untouched period of 5 minutes. But in the same times, for the 78 deceased donor, there was no case of heart or brain resuscitation, indeed no cerebral activity recorded on the bispectral index during NRP. And to complete the debate, Shepe and others performed a systematic review of the literature concerning the possibility of return of cerebral and cardiac activity after NRP. 12 of 410 articles identified by database searching were eligible for inclusion and concerned NRP in CDCD donors. And at the end, no return of spontaneous cerebral and cardiac activity was recorded among 493 donors. So brain reperfusion is a real risk only in case of misplacement of the aortic occlusion balloon, and a strict focus must be given by monitoring to exclude brain reperfusion. even if no cerebral activity was recorded in the previous studies. A clear protocol is needed to detect signs of brain reperfusion. The correct positioning of the balloon has to be confirmed using either X-ray or ultrasound. The disappearance of the pressure needs to be detected, for example, from radial invasive monitoring, which is easy, safe, and minimize the risk of brain reperfusion. Cyanosis in the upper part of the body or ECG activity are not recommended. A return to only pulseless cardiac electrical activity could occur, but does not count as true cardiac activity return because there is no restoration of circulation. Some authors raises the question about lung reflection and oxygen supplied after death declaration. Lung reflection being very important to minimize warm ischemic time for the lungs, but could be associated with a resumption of cardiac activity. The unit and kill them protocol suggests to avoid it, to delay lung reflection until a minimum of 10 minutes after loss of the circulation, to perform only a single vital capacity inflation of the lung, followed by the application of continuous positive airway pressure, or by clamping the endotracheal tube, and cyclical ventilation is avoided until the surgical team has started to flush the lungs. Alternatively, lung reflection can be delayed until the pulmonary artery is cannulated. Both maneuvers render the heart incapable of coordinated contraction. Extending NRP to include cardiothoracic organs is a recent development, restricted to the UK and Belgium, and not implemented in France. So I encourage you to read these two very interesting British papers if you want to know more about. After brain reperfusion, the other issue is the potential impact of organ donation on end-of-life practices, and more particularly the impact of ante-mortem interventions. There are differences concerning the authorization of ante-mortem interventions between countries, reflecting variable professional practices influenced by cultural, religious, and social factors in each country. In Spain, as we have seen already, heparin, ante-mortem cannulation, introduction of an aortic occlusion balloon inflated just 4 seconds are performed before WST. In France, ante-mortem cannulation is not authorized, but heparin and ante-mortem vessel localization using guide wires are performed. In UK, none of these are authorized. But every time ante-mortem interventions are authorized by the National Ethics Committee and are detailed in the national guidance. Relatives are informed about which interventions, and for example in France, a booklet is given to families, including all the information on appropriate level of details concerning WST, and also concerning all the ante-mortem and post-mortem interventions performed to preserve organs for donation. There are also differences concerning the location of WST and NRP setup between countries, reflecting also variable of professional practices. One must highlight that NRP offers the possibility to perform the WST in the room of the patient in ICU. It is a real solution when relatives were not allowed to be with the potential donor in the operating room, or when it is not feasible to block the operating room for too long time, and for example, is the case in France for both. In ICU, WST and administration and titration of palliative sedation is performed by the treating team, and there is no rush to transfer the deceased from the ICU to the operating room, allowing a more peaceful goodbye for the relatives. So to conclude, it is crucial to have consensus on the allowable circulatory interventions on the newly declared organ donor. In aim to maintain a strict adherence to the principles such as the dead donor rule and the preservation of dignity of the dying patient, and to assure confidence in the medical profession, it is recommended to have a national consensus with carefully addressed guidelines, written together with intensivists, surgeons, coordinators, and so, with an external validation by the National Ethics Committee, with detailed protocols, standard operating procedures, and checklists. It is crucial to establish an adequate, fair, and transparent communication to the relatives, with a specific informed consent about NRP procedure, with mention of all ante-mortem and post-mortem interventions, timing, prolonging ante-mortem care, location of WLC, and so on. Indeed, well-designed and maintained national registry are very important and may provide the basis for rigorous observational studies and offer transparency and clearness for ethical and practical management. Moreover, you will find all these keywords and this figure from the editorial written by Ben and others. If you are interested, you can easily download the guidelines from European countries, the report from the International Conference and Expert Panel, or the report from the ESOT about the consensus statement of NRP in the nation after security deaths. And you are all welcome to attend the sessions, Yes We Can, How to Start a DCD Program in Milan in August. Thank you for your attention.
Thank you, Corinne, for a very informative talk. Can I just remind everybody to put any questions into the Q&A box? So moving on to our second talk by Mr. Gabriel Oniscu, who is the director of the Edinburgh Transplant Centre and Secretary General of ESOT. He has a clinical interest in liver, pancreas and kidney transplantation, and his principal research focus is organ perfusion reconditioning transplant outcomes, and he's lead clinician for novel perfusion technologies in Edinburgh. And he's going to talk about NRP, organ utilization and outcomes. Gabby, over to you.
Thank you very much, Sarah, for this more than kind introduction. So, no conflict of interest, and please share this responsibly. A number of countries have now established DCD transplant programs, and there are a number of challenges that have been addressed in terms of a super rapid technique to extract the organs quickly, and designing pretty clear utilization criteria to maximize the outcome. However, despite all that, there remains uncertainty about the quality and the assessment capacity of the donated organs, which impacts on their utilization. I think it's quite clear that the DCD environment is rather unique, and the perimortem stages are compounded by the warm and cold ischemia, and it was hoped that the introduction of NRP, separating those two critical insults to the quality of the organs, allow the restoration of ATP with the aim of improving the quality and the outcome of the transplants. So let's take a closer look and see whether that has really been achieved in the experiences published so far. So first of all, we look at the liver, partly because the liver utilization with DCD has been relatively limited, and this is probably where the biggest impact so far the NRP has had. Looking at the UK data in a study comparing the DCD NRP livers with standard DCD procurement, you could see that beyond the fact that there is a lesser injury as reflected by the ALT, the significant reduction in the delayed early allograft dysfunction is quite marked. But the key challenge with the DCD liver transplantation is actually the development of ischemic cholangiopathy. And here are a number of studies published, including the 3 multi-center publications from the leading NRP countries in Europe. And you will see that the cohorts are pretty much similar. And very interestingly and reassuringly, despite the differences in practice that Corinne has alluded to, the ischemic cholangiopathy incidence is actually very low and significantly lower compared to what we've achieved so far in DCD with standard procurement. And other centers, smaller or studies as described on this slide, show similar results. Not surprisingly, the improvement in the ischemic cholangiopathy rates has translated into a better graft survival, as seen on the UK and Spanish data comparing with standard procurement. But the key question here, and this is addressed by the French data, is how much better are these grafts becoming? And the French study has compared the DCD's NRP with DBD liver grafts. And as you can see on the right hand side panel, those curves are identical. So clearly we've taken the worst graft possible and we brought them to the standard of DBD. A number of perfusion technologies are nowadays available. And as you can see here, there is a marked reduction, stepwise reduction in each of them, be it normothermic perfusion, down to similar rates with NRP achieved by the recent study published in the New England Journal by the Groningen group. However, it is important to note that all the ex situ perfusion technologies really operate within the same constraints of the organs that are already retrieved, and also with a fairly limited worm ischemic time, roughly around 30 minutes. In contrast, NRP has achieved better outcome despite longer worm ischemic time. And this study from Riccardo de Carlis' group in Milan clearly shows that with pretty extensive donor worm ischemic time, up to about 80 minutes, excellent results can be achieved. Of note, this study makes use of two perfusion technologies, NRP in situ and DHOPE at base. In the UK, where we've undertaken so far separate perfusion of the organs, we also looked at this issue and compared the outcome of the grafts, be it liver or kidney, according to the duration of the functional worm ischemic time, as defined as you see on the slide. And we were quite reassured to see that beyond 30 minutes, there is no negative impact on the outcome of the liver or the kidney grafts. And this really throws out of the window the significance of the functional worm ischemic time and allows us to push the boundaries even further. As a result, certainly in our center, we have widened the indication for liver transplantation from fairly restrictive for both donor and recipients to virtually any donor and any recipient with an extension of the cold ischemic time. But it is important to note that not just livers benefit from NRP, but other organs. And here we look at the kidney graft outcomes, first of all, from a UK series comparing the NRP kidneys with over 5,000 DCD kidneys. Two things are important to note. The delayed graft function is reduced by about 10%, and the GFR appears to be significantly better. Now, when we adjusted this for all the risk factors that can affect the outcome of a kidney transplant, the expected GFR increase produced by NRP is about 7.5 mils per minute, which essentially translates into 5 to 7 years of additional graft life for a patient. Similar results were seen in Spain, again, slightly different baseline figures, but again, at about 15 to 18% reduction in delayed graft function, and an improved serum creatinine at 1 year. The French group have again asked the question is, well, how much better are these kidneys? And in a study which compared the DCD NRP with 850 matched DBD controls, they demonstrated that the delayed graft function is actually half of that seen in the DBD kidneys, with a comparable function at the time of discharge. Little is known about the impact of NRP on the pancreas graft outcome. This preliminary data coming from the UK centers show that the benefit appears to be there. And although the numbers are small, there appears to be a slight reduction in the graft failures in 12 months, probably due to less thrombotic events. So how do we put all this into context? We shouldn't forget, as Corinne has said, about the DCD hearts, and certainly the UK experience show that they've achieved comparable outcomes with DBD hearts. But when this was explored further in a recent publication by the Papworth group, the use of NRP, particularly extended into TA NRP, yielded significantly better results as compared to a direct procurement and ex situ preservation on normothermic machine of the heart. So if we were to sum up so far, better results across for all organs, but also we've achieved over the last 10 years, certainly in the UK, on increased utilization of organs with NRP. And if we take a little bit of a closer look to this, first of all at liver, this is showing the journey between the donor and the transplant. As you can see at each time point, there is an attrition rate for the organs. So the NRP in red is significantly better compared to the standard DCD, but not quite there in terms of DBD utilization. However, when we've adjusted the utilization for the quality of the graft using the donor risk index from FENG, or the UK donor liver index designed by Dave Collett and colleagues, the odds of a liver being transplanted if it has been NRP increased by 3-fold. Similar results were noted for kidney, where the increase was 1.6-fold. And really pretty much comparable with what we've seen in the DBD scenario. And similarly in pancreas, adjusted for the donor risk index for the pancreas, there's an utilization that's increased by 1.7-fold. Lastly, but not to be forgotten, is the fact that NRP is the earliest intervention that we can do in any donor, and as such has the potential of expanding the donor pool. And here is a snapshot of our transplant of NRP activity. And on the far right-hand side, you can see that we've attended donors where only kidney retrieval was planned after livers were turned down by every single center in the UK. However, based on the parameters that we've seen and we will discuss later on, we're able to rescue 30% of those grafts. So there is a huge potential that is still untapped in terms of donors that are turned down purely on the history. And this is supported by the fact that you're able to do the analysis, and you can see the rescued livers in blue, pretty much identical to the livers where NRP was planned and the livers were transplanted. So I'll conclude saying that NRP is really one of the highest, one of the most disruptive technologies in DCD donation and transplantation, and has shown that we can increase organ recovery rates, and also is likely to increase organ utilization across a number of organs. This has also been supported by an excellent clinical outcomes for all, not just for one organs, and therefore, given the benefit across so many organs, NRP should really become the gold standard for organ procurement in DCD. This is a team effort, and this is the team that works with us in Edinburgh, and I'm grateful for all of them and the collaborators in Cambridge. And thank you very much.
Thank you, Gabby. You've got some really excellent results there from that programme. Would you like to introduce the next speaker? Oh, you're on mute, Gabby.
Yeah, typical. It has to be one who does it. So it gives me really great pleasure to introduce the next speaker, who's my colleague, Chris Johnston. Chris has really been a breath of fresh air to the NRP program and has made tremendous contribution in terms of education and training. And he's going to talk to us today about, oops, sorry.
I think we've skipped Amelia.
Yep. Yeah, I do apologize for that. That's me not looking at the program. So, Amelia, I'm very sorry to do that to you. You're a friend and a colleague. So Amelia is a surgeon currently in Barcelona in the process of moving to Madrid. She's got a training in the US and Spain. Together with the Barcelona group, has had a huge amount of research and clinical work in the area of transplantation, donation, and particular organ perfusion preservation and NRP. And I'm looking forward to hearing her thoughts on different approaches to NRP. Amelia, over to you.
Hello, everyone. Thank you very much for the opportunity and the invitation to present today on the different approaches that can be used to establish normothermic regional perfusion in donation after circulatory death donors. My name is Amelia Hessheimer, and I am an HPB and transplant surgeon currently working at the hospital clinic in Barcelona, Spain. These are my disclosures, and this is a social media disclaimer. To give some background, normothermic regional perfusion was first applied clinically in the hospital clinic starting in the late 1980s and early 1990s in the context of uncontrolled DCD, to help recover kidneys and livers from complex donors suffering out-of-hospital cardiac arrest and a prolonged period of warm ischemia. Using postmortem NRP and a strict acceptance protocol, we have been able to successfully transplant uncontrolled DC kidneys and livers with donor warm ischemia times exceeding 2 hours. This experience has subsequently been replicated by other centers in Europe, most notably by groups working in France and Italy. NRP performed immediately after donor hypoperfusion and cardiac arrest and the declaration of death has been seen in the context of experimental and subclinical studies to restore depleted energy substrates, remove metabolic waste products, and increase levels of endogenous antioxidants prior to cold preservation and organ recovery. In this sense, postmortem NRP effectively converts the period of donor warm ischemia into one of ischemic preconditioning. These pictures provide a visual representation of the dramatic effects that can be achieved with postmortem NRP in DCD. After 30 minutes of complete cardiac arrest, the liver and intestines are congested and ischemic. After only 30 minutes of NRP, they recover their normal aspect and viability. The liver is well perfused and produces bile. The intestines also present normal peristaltic function. For the aforementioned reasons, when controlled DCD was first piloted in Spain in 2009 and regulated via national protocol in 2012, the option of performing NRP was offered to all the abdominal organ procurement teams at the outset. Based on the successful application of postmortem NRP in uncontrolled DCD and controlled subsequently, this form of donation has seen nearly exponential growth in Spain for every year since 2012. In the context of controlled DCD in Spain, cannulation for the establishment of NRP may be performed either prior to withdrawal of life support therapy, which is antemortem cannulation, typically performed in the groin, or after the death declaration, postmortem cannulation, which is typically performed in the abdomen. Based on recognition of the rising importance of NRP in DC transplantation, the European Society of Organ Transplantation organized a group of experts in 2020 for Transplant Learning Journey 2.0 in order to help provide guidance on the important technical and logistical issues associated with the application of NRP. I was very lucky to have been able to participate with this international group of experts in preparing a set of consensus statements on NRP in DCD, which I am pleased to announce have just been accepted for publication in Transplant International. You will soon be able to read in greater detail all of the consensus statements in TI. Today, I would like to summarize some of our primary recommendations regarding the technique for establishing NRP. Depending on local or national legislation, in some settings, some antemortem interventions are allowed. These may include heparinization, guide wire placement for femoral vessel localization, and/or actual cannulation of the femoral vessels to set up the NRP circuit. These antemortem interventions should always be performed in accordance with the prevailing legislation and ethical constructs in each donor hospital. As can be seen in the table, Belgium and Spain allow heparinization prior to withdrawal of life support therapy and even antemortem femoral vessel cannulation in some settings, depending on the donor hospital policy. In France, Italy, and Norway, femoral vessels can be accessed with guide wires or small bore catheters prior to withdrawal of life support therapy. In the Netherlands and the UK, on the other hand, no antemortem interventions are allowed. In these figures, you can see how antemortem cannulation may be performed via the Seldinger technique. Guide wires are placed in the femoral artery and vein and used to introduce cannulae into the vessels. These cannulae are left clamped and connected to the tubing of the NRP circuit. In the contralateral femoral artery, a Fogarty aortic occlusion balloon catheter is introduced into the descending thoracic aorta, distal to the left subclavian artery. Radiographic imaging is performed to ensure adequate positioning of the catheter, which is left deflated until death has been declared. Once death has been declared, the balloon is inflated to include all the aortic arch vessels, which is necessary to maintain permanent lack of blood flow to the brain and brainstem while NRP is running. With the balloon fully inflated, NRP is then started. These are some pictures that were provided by our international colleagues depicting the different aspects of cannulation for NRP. In France and Italy, where antemortem vessel localization with guide wires is permitted, these thin wires may be placed, but actual cannulation is only performed following the declaration of death. When cannulation for NRP is performed post-mortem, which is the case in the majority of centers currently using NRP, this may be performed either in the open abdomen, in the abdominal aorta and IVC, or iliac vessels, or in the groin in the femoral vessels. The latter, in particular, in cases where antemortem vessel localization with guide wires or small bore catheters has been performed. Here we have images of the Fogarty balloon catheter being inflated in order to block the supraceliac aorta so that NRP may be started. The involvement of specialized perfusionists is critical, as some resuscitation of organs during NRP is often needed, especially when the donor warm ischemia times have been prolonged. These are more pictures depicting the aspect of the donor, the operating room, an open abdomen and chest with NRP running. One of the great advantages offered by postmortem NRP and DCD is that it converts the stressful rush to flush and get the organs out as quickly as possible into a relatively standard donation, whereby the macroscopic aspect of the liver and pancreas and the bowel can be rather extensively and adequately assessed. We recently evaluated data from the Spanish Liver Transplant Registry, Registro Español de Trasplante Hepático, or the RETH, regarding all controlled DC liver transplants performed in Spain between 2012 and 2019. When evaluating according to recovery method, all the different donor warm ischemia times, including total, functional, and asystolic warm ischemia, were the shortest for cases with NRP and antemortem cannulation. Techniques of supragrappa recovery had intermediate donor warm ischemia times. Given the additional steps needed to establish the circuit, including both arterial and venous cannulation and clamping of the donor's supraceliac aorta, controlled DCD cases with NRP and postmortem cannulation had the longest donor warm ischemia times. In spite of the fact that NRP with postmortem cannulation may extend donor warm ischemia time slightly, with functional and asystolic warm ischemia times averaging about 7 and 4 minutes longer, respectively, versus NRP performed with antemortem cannulation, our own results, as well as those of other international experiences, do not indicate that this has a significant negative impact on outcomes. Since 2019, an increasing number of reports have come out describing larger and larger series of transplantation of controlled DC livers recovered with NRP. Excluding one early case series from the United States, most have come from Europe and describe rather low rates of biliary complications, and in some cases, little to no ITBL, even using grafts from donors of advanced age, and in some cases, with extended donor warm ischemia. In summary, postmortem NRP is in controlled donation after circulatory death donors may be performed using either antemortem or postmortem cannulation to establish the NRP circuit. While postmortem cannulation does extend donor warm ischemia time somewhat, current evidence does not suggest that this has any significant impact on subsequent post-transplantation outcomes. As such, the specific technique used to establish NRP should adhere to the prevailing code of ethics and legislation. Thank you very much for your attention.
Thank you very much, Amelia. That's the most excellent talk. Very, very informative indeed. So moving on to our last talk before we take a quick break is from Chris Johnston, who's a transplant surgeon in Edinburgh. And his interests include liver transplantation and novel organ perfusion technologies, including NRP and the OrganOx system. And he's going to talk us through the NRP process. So hand over to you, Chris. Thank you.
Thank you very much. So no conflict of interest to declare, and please do share far and wide. I'm going to give an overview of the NRP process from the Edinburgh perspective. And this, to begin with, this is our team. So one surgeon, one assistant, scrub nurse or equivalent, and a theatre practitioner for cold perfusion, as we would have for any abdominal retrieval, and then with the addition of an advanced perfusion organ preservation specialist. And this is an additional team member that will manage the NRP pump and manage the perfusion process. A quick outline of the kit that we have. Standard as for many centres. We've got the pump, CardioHelp ECMO machine with heater there, purpose designed disposable NRP circuit, a separate box for our point of care blood gas and biochemistry analyzer, and then an additional kit bag with everything that's required. And this has been condensed over a number of years, such that we can now travel in a single vehicle with a team of 5 and all of the equipment we need. And we regularly fly with the kit now on a small turboprop King Air aircraft. This is the donor hospital setup, similar for any of our standard retrievals. And then with the addition here of the NRP machine with access to the local air and oxygen supply, a sampling table for point of care analysis, and we'll come on to the bloods that are taken in a moment, and then a sterile basin for the circuit tubing that's brought onto the table as soon as the drapes are placed. I've got an outline here of the bloods that are taken. We'll come to the specifics in a moment, but essentially we take a series of bloods every half an hour for the 2 hours that the NRP perfusion is running, and you can see in the picture on the bottom right here that we set all of this up with all of the cartridges ready for each time point so that one person can manage both the perfusion and the pump and each of the blood sampling at the same time. And this allows us really to be a completely self-sufficient team now and to travel to any donor hospital without any specific additional requirements. As part of the process, when we arrive at the donor hospital, typically the surgeons will take a handover of the donor history and specifics for the individual retrieval, and then prepare the drugs for the perfusate that you can see there, as well as ensuring that blood is available from the local donor hospital. And our standard protocol would be to cross-match 4 units. We wouldn't normally require all of those. The next, we've got an overview here, slightly speeded up from normal. We've got the process for setting up the pump and being ready to go down to about 30 minutes. And essentially this incorporates setting up the machine, setting up the disposable circuit, and priming and de-airing the circuit, and then running through and rehearsing with the local team the process for going on NRP and coming off at the end. And so that's roughly down to 30 minutes now as a routine, so that it doesn't really add any additional time over that it would take for standard DCD retrieval in terms of setting up theatre trays and whatnot. Important point to mention just about the specifics of the machine setup. You can see here the circuit that right at the very beginning, when we're setting up the circuit, the cold perfusion line is primed and added to the arterial line, the sort of final tubing going to the aortic cannula. And particularly at the beginning, starting out on this process for NRP, I find that very reassuring that it literally takes a couple of seconds to clamp off the NRP circuit and run and start cold perfusion, so that if there is a problem that's not manageable, we could proceed with the standard DCD retrieval and have the organs out in a standard DCD time frame. I find that very reassuring. Just as an overview, the standard approach for the Edinburgh team is aortic cannulation and cannulation of the cava. We'll show that in the video of the whole process after this talk. But as Amelia mentioned, femoral cannulation is a very helpful option to have, and we have used this recently for a number of donors. Here is an example of a donor with 10 previous laparotomies, and the liver was retrieved and transplanted with NRP with femoral vessel cannulation. It would have been impossible, certainly impossible as a standard DCD, and likely impossible with abdominal cannulation. We place an aortic arch cannula, and that's left open to air, and that's really to confirm the absence of any oxygenated blood perfusion to the brain. So that is placed before the pump starts and is left open for the duration of the NRP circulation. I'll really give an overview now of the process or priorities for when we go on NRP. And I've separated that into really 3 aspects: managing any bleeding in the donor, managing the pump, establishing stability on the pump, and then performing an objective organ assessment, particularly for the liver. This is a quick overview of us starting. So the cannulas are in, and we're just going to go on the pump here.
Okay, right, ready? So we're going to come off now. The venous line up. Ready for artery? Okay, that's artery found off.
And really just to highlight there the communication, the importance of that between the surgeons and the perfusion team right next to us, particularly in the first couple of minutes in establishing stability in the pump. I should mention this was an NRP retrieval in our home institution, that there are a lot more observers and trainees than the standard core team that we would normally have. So just to overview, when we're going on the pump, our first priority is for the reservoir volume, to monitor that and replace volume quickly if necessary with blood or gelifusing. And if there's an ongoing drop in reservoir volume, to proceed to troubleshooting. And Fiona is going to speak specifically about that in a subsequent talk. The flow rate will aim for 2 to 3 litres a minute, and we'll adjust that according to the volume in the reservoir and the bloods as they come back. We'll talk more about that in a moment. And then the other thing is, as the pump starts, any hemorrhage or potential for hemorrhage will become apparent fairly quickly, and to deal with that as quickly as possible. Hemorrhage can either be in the abdomen, and that's most commonly around the aortic or caval clamps and cannulas. And you can see here that some bleeding is most commonly from behind the cannula, from backflow, from lumbar vessels. And these are generally fairly easily dealt with. An artery forceps placed horizontally behind the cannula is generally very effective and straightforward measure. Bleeding in the chest is another possibility. There's significant variation between donors. In most donors, the venous pressure in the chest is low. So you can see here, this is the back pressure from the aortic cannula. But there is variation, and sometimes the venous pressure can be significantly higher, and this can lead to bleeding, particularly around the site of soft tissue dissection to get to the aortic cross clamp. Generally, this is easily managed either with diathermy or even packing the chest if necessary, but it's important to look for so the significant volume isn't lost from straightforward bleeding that's just concealed in the chest cavity. When we come to managing the pump during NRP, as I mentioned, achieving a stable volume and flow rate at the beginning is one of our first priorities. And then as the first set of bloods comes back, the first things we'll look at is the pH. If pH is less than 7, we will give bicarbonate to correct that, generally 20 mils bicarbonate or thereabouts. And it's important to give that as a bolus right at the beginning with no further subsequent boluses, because that can then interfere with interpretation of the blood results for liver function. We typically use mixed venous oxygen saturation, and we can adjust the pump, and we have multiple parameters we can adjust to improve oxygen delivery if required, and increase the oxygen flow rate. We can increase the pump speed if the reservoir volume allows, and that's similar to increasing cardiac output. And we can increase the hematocrit if necessary. And hematocrit we keep over 20%, and as mentioned earlier, we'll generally replace with blood at the beginning if we can, and try and avoid hemodilution wherever possible. Once stability has been achieved, and generally that's within 5 to 10 minutes on the pump, then we move towards making an organ assessment. As Amelia mentioned, some of that is a macroscopic appearance of the liver. We typically place a T-tube in the bile duct now to get an analysis of volume bile produced by the liver during NRP, and allowing bile sampling at serial time points along with the bloods. And then we also get our sequential bloods. And with that, it's a combination really of parameters that will allow us to monitor the perfusion, and parameters that will allow us to look at the liver function and make a decision as to whether this is a safe liver to transplant or not. Specific things we're looking at, so lactate to begin with, and this really correlates with hepatic function and should fall considerably during the course of the 2 hours of NRP. It can be affected by a venous clamp. So typically, as you'll see in the video shortly, we place an SVC and IVC clamp in the chest. The oxygenated blood flow is confined to the abdomen, so the thorax is hypoperfused, and if venous blood is returning from the thorax, the lactate will be high and will artificially maintain a high lactate even in the presence of a very good liver. So we try and place the venous clamp and keep it on for the duration. ALT is indicative of liver injury, tends to rise a little bit after a period of warm ischemia, but if it rises considerably, we would decline the liver, and 500 is considered a threshold. And then glucose maintained by a functioning liver is also an important aspect to consider. So in summary, I've given a quick overview there of our priorities when we're on NRP. I should say that present all of the potential issues and problems in a way, but actually most of these are addressed and dealt with within the first 10 to 15 minutes. And then we have time for considered liver assessment, discussion with colleagues, preparation of paperwork. There's no doubt that our team and that the local centres we visit would certainly prefer this to a standard DCD retrieval in terms of process. And with the obvious advantages that Gabby has already alluded to of identifying livers that are not going to work, we do sometimes get surprises from young DCD donors with very poor function that would almost certainly proceed to PNF. We increase the organ recovery rate. We use several livers that we would never have considered using as standard DCD. And there's no doubt in our minds that this should progress to be the gold standard for DCD retrieval. Thank you.
Thank you, Chris. Very excellent talk. We've got a few minutes before the break. So there's a number of questions being posted in the Q&A box. We've answered some of those, but I think some of them are quite interesting that we'll open up to everyone. So there was a question: so do we need to use an ECMO oxygenator, or can you just use a traditional one? You know, because there's a considerable difference in price. Maybe Chris or Gabby, do you want to comment on that?
Chris, do you want to take that?
Well, certainly, I mean, I think in terms of oxygenation, this is more than a simple, you know, an ECMO type machine for membrane oxygenation is what would be considered for running for 2 hours here and to establish as physiological process as possible. Certainly my consideration that is what's required here. And if these are organs that we are going on to transplant, that's the standard that's been achieved, and a simple oxygenator would not be sufficient to achieve the you know, physiological requirements that we would need.
I think, Chris, I think the question was more, obviously the ECMO one is certified for 30 days and it comes at a different price. And I think whether you can use a simpler one, not necessarily one that's validated for 30 days, because really we're using it for 2 to 4 hours in most experiences. Corinne and Amelia, what is your preference in Spain and France?
I mean, if you're talking about ECMO in terms of the duration, no, you don't need a filter that can, or a membrane oxygenator that can work a week, but you do need to have an oxygenator that allows for an adequate flow. So I don't know what the question really goes to. See, if ECMO, I generally think about the duration, but they're just as long as the flow through the membrane oxygenator is adequate. It doesn't have to be heparin coated because you can heparinize the circuit. So I don't know if that's answering the question. If that's what I would say.
But certainly I'm not aware of anything. Gabby or Fiona, perhaps you could add to that.
Yes, no, I think there are similar oxygenators that that work with this circuit that come at a cheaper price because they are not certified to last as long as the 30 days.
Corinne, what do you use in France? You're on mute, Corinne. Sorry.
Yes, in France, it's the same device. And it's the reason that it was very easy to install the program in France, because there is many ECMO devices in France in all the intensive care unit. So it was a plus of an advantage for us, because we use the same device as the therapeutic, exactly the same. And it's only for 4 hours. And I don't know, you need more information?
Okay, thank you. We have a non-answered question. So from an anonymous attendee, what about the ideal extracorporeal blood flow? How do you calculate it? How do you modify during perfusion? Does anyone want to take that?
I can touch on that from our experience. So we mentioned briefly during the talk there that we monitor mixed venous oxygen saturation, and that gives an idea. So certainly if the SVO2 is low, then increasing the blood flow will effectively correlate to, it's similar to increasing cardiac output, increases oxygen delivery. So it's a combination of pump flow rate, hematocrit, and oxygenation. So 2 to 3 liters a minute is our target, but we would adjust it according to the bloods that come back if required. It's not that often that it is required, but that's what we would look at.
Based on what we did for TLJ, in Spain, the target is generally around 2.2 to 2.4 liters per minute per body surface area, meters squared. And there are other countries that use targets of 3 to 3.5 liters per minute, 3 to 3.5 liters per minute without looking at the body surface area, to 2 to 3 liters per minute. So it depends on who's running it. I think when you have a perfusionist, they're obviously going to adjust more finely to the body surface area ratio than opposed to say just a technician or a student or someone else who's running the perfusion.
Okay, just looking through the questions. And there's another question just come in regarding training required to properly do the NRP. Is that embedded into the transplant general surgery curriculum, or if not, what are the limiting steps from a training point of view? Thank you. Maybe Chris or Gabby, maybe you want to answer that?
Yeah, so at the moment it's not part of, certainly in the UK, it's not part of the curriculum, but it's part of the mandatory organ retrieval procurement course. So anyone who wants to be certified in an organ procurement needs to undertake a training in a particular center and go through a hands-on training course. The basics of NRP are taught at that course, but then there isn't beyond that at the moment. We're working on establishing proper training courses and expanding this. In centers who are new to the NRP, there is a proctoring system in place whereby experienced surgeons from other centers who have already started a program will come and help them set up and supervise the first procedures, and there's always someone available. But on an individual basis, I think that's just evolving at the moment, and there'll be some hands-on training courses certainly later on in the year.
Okay. We did have a previous question about the outcomes from lung DCDs and NRP, and I think Corinne had given quite a detailed answer to that, but just wanted to know, did you want to add any other comments?
No, in the answers in France, we observe very excellent results for lung transplant. And for example, the 1-year graft survival is 91%. And we observe no assistance at the end of lung transplant for 75% of recipients, with very short ICU stay, because it's less than 15 days for 75% of recipients. And you have to know that in France, the lung asystole has to be less than 90 minutes. And very important, ex vivo perfusion is mandatory after lung recovery. And about 80 recovery ex vivo perfusion identified 10 lungs that it's not properly to be transplanted. So it's a security for the recipient, and the ex vivo perfusion is mandatory. And thanks to the machine, we 10 transplant were avoided because the graft was very poor quality.
Okay.
Very quality.
Thank you. And then just one last comment really to a question about NRP followed by using NMP for the liver, and Gabby had replied about the blood, so it suggested that it wasn't a good idea to use the blood from the donor whilst you're doing normothermic perfusion. And the questions come back, so why do you think it's better not to use the same blood? Gabby, I don't know if you want to answer that.
Well, I think there are a number of reasons. First of all, obviously, circulating blood that gets diluted and with quite a lot of extra fluids on, and you'll have all sorts of things in the blood that you don't want necessarily to move on to the next recipient. It muddies your waters in terms of how you interpret the data. And I think the other challenge is you may have a recipient of a compatible but different blood group, and there may be restrictions in terms of what you can use there. I think from an NMP point of view, I'd like to start fresh, because we know where you have your baseline, rather than having blood that's already been recirculated in a circuit for a couple of hours and then moving into a different circuit, and it causes a lot of hemolysis and other problems. So I think it's safer that way.
Okay, thank you very much. Well, I think there's no more questions at the minute, so I think we'll take a 10-minute break and then reconvene at 7:10. Back on. So welcome everybody back. So to the second part of this webinar. So in the next session, we're going to really focus on sort of the technical aspects and have a case-based discussion at the end. So the next talk really is a practical demonstration of knife to skin and going on to the pump of NRP. And I think that's going to be led by Chris Johnston. Okay, so if we can.
Thanks very much, Sarah. So this video is pre-recorded. We'll run it for about 10 minutes, and then the team will take questions at the end. Thank you.
The following video shows a recent abdominal NRP retrieval performed by the Edinburgh team. Audio from theatre has been preserved, and the video is shown at normal speed to give as realistic a demonstration as possible.
Heavy scissors in a second.
Exposure of the aorta and cava here, taking care to minimize bleeding later on the pump as much as possible.
Yep.
Yep. We'll use the 26 cannula.
No problem.
So, scissors, thanks. Yeah, and then we'll take the 26.
Is it primed or ready to go?
It's not primed or.
Okay.
Yep.
An aortic cannula is placed with the same technique as for a standard retrieval, with a heavy tie distally and a snugger at the top. The cannula is placed with a clamp over its other end, then connected to the arterial line and flushed with fluid from the arterial line to prevent any clots from forming in the cannula itself.
Let's have the reds. Yeah. And fill in. Yeah, no. That's good. Okay, right, aortic, the arterial line off just to flush. That's good, okay. Yeah, we'll go for the snugger in a second.
The cava is prepared in a similar fashion to the aorta, with a tie inferiorly and a snugger superiorly.
Yep. Snugger.
Any lumbar vessels between the tie and the snugger can cause significant bleeding and are best dealt with at this point if possible.
Coil, medium legger. Okay, so we'll need 2 coils.
Clips are placed on the cava in the 10-2 and 10-past position on the clock face to hold the lumen of the cava open after venotomy is made.
Right.
It's important to expose a reasonable length of cava here so that it can be compressed superiorly with the surgeon's left hand
Ready with the
whilst a venotomy is made,
cable
and the cannula is then advanced with the surgeon's right hand, and this avoids significant blood loss at this step. The cable cannula is connected to the venous line of the circuit using heparinized saline to prevent any bubbles from forming, and clamps are then removed from the venous line alone, allowing up to 1.5 liters of donor blood to return to the circuit reservoir.
So the venous line back. Knife in a second.
Yep, and the roll for a chin.
Aortic clamp. Okay. Scissors. We'll need 2 mayos in a second, and then we'll go with the DLP cannula. Okay, 2 mayos, thanks. Yeah.
Just like a normal.
DLP cannula.
After clamping the descending thoracic aorta, the aortic arch is exposed and an aortic arch cannula is placed that is then left open to air. This is an obligatory step to confirm the absence of cerebral perfusion with oxygenated blood.
Need right, scissors. Oh. Scissors off. Yeah, and this. And then a pair of forceps. 1 second. Yeah, file and forceps, sorry. Forceps, please. Just see over here. Yes. Okay. Right, vascular clamps, venous clamps, that's that back. These over to you. No, they say those over to you.
As a final step, clamps are then placed on the SVC below the insertion of the azygous vein and on the IVC as high as possible, checking the position of the caval cannula at this point to ensure it's below the diaphragm.
Okay, starting on the pump now.
That's been took the clamp off.
Yeah.
So it's running 1.6 litres of steady in the reservoir.
So that's us established on the pump with no bleeding or instability. Depending on the venous pressure in the chest, occasionally a small reservoir such as 30 ml syringe is required for the aortic arch cannula.
That was a very, very clear video, Chris. Thank you very much, and the whole team for that. I think people have found that very useful. I think we've probably got time for a quick question from Jotmans, and she's asked, or she said that they would place the venous cannula first and then start venous drainage whilst placing the arterial cannula and clamping the aorta to reduce the venous congestions. Any thoughts on that?
That wasn't me. So I can answer that. So I've seen that elsewhere, that there's this emphasis on placing the venous cannula first, and I think certainly starting off, I was much more comfortable. Our protocol was to place the aortic cannula first. That's in, as I showed earlier, in this machine setup, you have the option of going cold there right at the very beginning, and I think that particularly starting off is important, that if there's significant bleeding from the cava or venous bleeding, your cannula is in, and whatever time it is, you can go cold in a matter of seconds. So there's a benefit with that. The process of the technique that was showed there, even with that, placing the venous cannula second, would get up to 1.5 liters of venous blood back to the circuit. So I'm not sure how much of a difference or how much additional blood you would get by placing the venous cannula at the beginning. And I think there is a slight risk, as I mentioned. I don't know if Gabby, if you would have anything to.
I think we started, as you said, just to keep the procedure simple with the fewest modification from a standard DCD retrieval. I guess where the venous cannula could go in first is if you have a direct procurement of the heart, because then it allows you to vent 1.5 liters, which they will need for the machine perfusion, whilst you carry on establishing the arterial circuit. So if we do have that situation, perhaps yes, we could switch them around. What we've done here is just keep things as close as possible to a standard DCD.
Venus just commented to say it's not about getting blood, but getting venous congestion off the liver as soon as possible.
Yeah, I mean, we have not seen that much of a problem, to be honest. I think it's a pretty big venous cannula that we used, the 3-stage, and we've not seen that issue in our practice, at least anyway.
That's assuming that you're draining to a reservoir then, because not everyone uses a reservoir. So I don't know, you have a reservoir in your circuit to be able to drain blood to something.
Yeah, I think as far as I'm aware, I mean, that's a good point. Most people would use a reservoir. I'm not sure what Riccardo or Corinne would have to say if they use an open or a closed system.
In Italy, we use a closed system, but we usually start with arterial line and with the venous one, but we usually perform it percutaneously and not with an open abdomen. So this is the main difference in Italy.
It's the same in France, percutaneously and closed system.
Okay, I don't think there are any more questions after that. So, Gabby, do you want to introduce the next speaker? Which is
yes, thank you. Hopefully this time I'm going to get it right. So it's we heard from Chris and we've seen how it goes well. Next speaker is going to talk to us about when things don't go well and how we can fix it. And it gives me great pleasure to introduce Fiona Hunt. Fiona is the leads a team of advanced perfusion and organ preservation specialists whose sole role is looking after NRP and every other perfusion technology that we are involved with. She has been absolutely instrumental in setting up our NRP programming, getting it to nearly 100% coverage at the moment. So Fiona, over to you.
Thank you, Gabby. Thank you for your introduction. 2 seconds. Can I just check you can see my slides? Yeah.
Yes, it looks good.
Yeah, you can hear me. Yeah. So I can confirm I have no conflicts of interest and happy for this presentation to be shared responsibly. So the majority of NRP cases run smoothly with steady volumes in the reservoir good flows on the pump and a relaxed team at the table. However, like any procedure, problems can be encountered, and therefore the team needs to be able to identify when there's a problem and how to deal with it in a timely manner. So many of these problems can be avoided or easily managed with good communication, and when the team are working from a robust protocol and have been through comprehensive education and training, including dry runs and simulation. The simulation provides the opportunity to consolidate theory, skills, drills, and measure performance. So teams are then well prepared for actual donor attendance. So despite careful preparation, issues can still occur and can arise in 3 key areas. And we're going to look at these in more detail. So first of all, starting with issues that occur on the donor. Now, problems can initially be encountered gaining vascular access. The choice between abdominal and femoral cannulation should be considered, and therefore the technique should be tailored to the donor situation. Now, bleeding is one of the key challenges when establishing and maintaining NRP. Therefore, the team should make appropriate use of diathermy, vascular snuggers, and have volume replacement readily available. So bleeding can manifest in 2 ways. A dramatic drop occurs due to bleeding around the cannula sites or in the chest, and it's important to spot it and fix it quickly. In preparation, volume replacement should already be pre-connected to the reservoir and the pump turned down or temporarily stopped until surgical management has been successful and reservoir volumes have been recovered. Alternatively, a gradual drift in volume can be noticed on the reservoir due to vasodilation rather than a major bleeding point. However, it requires the same approach in terms of pump management, but in a less hurried way. So once ensuring there are no donor-related issues, we can move on to challenges with the circuit that can be considered. So before thinking about these challenges encountered with the circuit, remember the circuit has a venous limb and an arterial limb. Obviously the venous before the oxygenator and the arterial after the oxygenator. And we've looked at volume loss due to bleeding, but volume loss can be due to a diminished venous return caused by kinks in the cannula or circuit tubing, or by excessive suction on the venous arm of the circuit causing collapse of the cava around the cannula. It can also be due to air or clots that can block the cannulas or circuit. And it's worth noting that a sudden loss of venous return can rapidly exhaust the reservoir, and 1 litre of volume in the reservoir can disappear in 20 minutes at a flow rate of 3 litres per minute. So kinks can sometimes go unnoticed if the circuit has been hidden under the drape, but this can be easily resolved by manipulating the tubing to restore the venous return. The collapse of the cava around the cannula can be recognised with a bounce or a jump on the venous line just before the reservoir. Manoeuvres such as reducing the height difference between donor and pump to reduce the suction effect is usually the first line of defence, or partial occlusion of the venous line with a clamped tubing may also be effective. And sometimes readjusting the venous cannula is necessary, and this is when the use of snuggers are helpful as they are easily loosened rather than trying to cut tight ties. Alternatively, this can be remedied by stopping the pump, waiting for a couple of seconds, and then restarting the pump at a lower flow rate. So air in the circuit. Air in the arterial limb can embolize and impair perfusion of organs. It is therefore important when establishing NRP to de-air the cannula and circuit completely and to ensure the cannulas are firmly tied in. Small amounts of air on the venous side will run off into the reservoir and cause no harm. However, if larger volumes occur, this may cause an airlock and will block the blood returning to the reservoir. In this situation, this airlock needs to be walked along the tube into the reservoir to unblock the venous return. Air can also get trapped in the oxygenator. A rapid loss of volume going unnoticed can result in the reservoir completely emptying and air getting into the oxygenator. And as alarming as this may seem and sound at the time, it can be quickly resolved with the following steps. by clamping off the circuit and turning down the pump, replacing the volume, and then we can de-air the oxygenator by attaching a large syringe and aspirating the air that's trapped. So once we've got rid of all the air that's trapped, we can then close the pressure line and restart the pump. So we'd unclamp the venous line first, and then unclamp the arterial line and restart the pump. So it's really a quick fix when the necessary skills and drills have been well rehearsed. So clots were a major concern when we started the NRP programme due to circulatory standstill associated with DCD donation. And they can occur on either limb of the circuit and can embolise into organs as well. Fresh clot is most likely to occur first on large surface areas such as the oxygenator and leukocyte filter and will impede the flow. This is caused by no or insufficient heparin being added. So to prevent this, heparin should be added to the priming solution and allowed to circulate around the circuit before starting perfusion. And we would add 50,000 units to our prime, so a fairly hefty dose. And Hepsal flush would be used to de-air prior to connecting the cannulas to the circuit. And also bear in mind, it may be needed may be required to add additional heparin if large volumes have been lost during the perfusion. And an ACT, an acting clotting time, can be performed to monitor this. So clots in the oxygenator are a more significant problem, and in addition to an increase in reservoir volume, there is an increase in pump speed to try and compensate for the reduced flow. An increase in the difference between pre and post oxygen membrane pressures, known as delta pressure, would confirm this diagnosis. In most cases, this would be an unsalvageable situation. So as with all troubleshooting scenarios highlighted, we always have the backup of going to cold perfusion at any time if troubleshooting attempts fails. So going cold, the standard cold perfusion line should be prepared and connected to the circuit. And when cold perfusion starts, it's important that there's a clamp to clamp off the circuit. You know, we've already got one here that's on a bypass line, and there we clamp another one just below the leukocyte filter. The cold perfusion lines can then be opened, both at the circuit end and at the line end. Lines are opened, and then we can observe the arterial blood being cleared by the cold perfusion fluid. Organ procurement can then proceed in the same manner as it would for any other standard retrieval. And finally, problems can be encountered with the pump, but they are very rare, and these would be specific to the device of choice, and therefore troubleshooting training with the manufacturers would be recommended. So in summary, NRP problems can arise during in 3 areas, which in most cases are reversible with clear communication and a well-prepared team. However, if troubleshooting attempts fail, we would go cold, and whilst you may not have gained anything, there wouldn't have been anything lost. Thank you.
Thank you, Fiona. That was a very clear and valuable presentation. I think people would agree with that. I mean, clearly you've got considerable experience and know all the little tips with all the issues that can happen. I don't think there's any questions in the Q&A box, but can I have just a quick question? So in terms of clots, I mean, have you ever considered using any anti-thrombolytic therapies in the system?
Well, the only thing that we've added so far is heparin, and we had previously, in our previous protocol, we used to give heparinized bags that the SNOS used to take back to ICU and attach to a venous line or an arterial line. And of course, because there's no pre-mortem interventions in the UK, these would be opened after asystole and after the no-touch period. However, it was deemed we weren't very sure whether this was making any difference or not. And I think we were doing it in Edinburgh, and the Cambridge group weren't doing it, and there was really no difference in our results. So we decided to leave it out of the protocol for now. But as far as I'm aware, there's been nothing else added except heparin.
Sarah, perhaps I can touch on that. We haven't, and it's interesting that despite all this sort of hype about potential clots in DCDs, we really haven't seen many. And even with the prolonged demonstration that Chris has shown you, 19-20 minutes is actually okay. It's very rare that you would find clots. I don't know whether Amelia you've seen or Corinne or Riccardo in your practice, but we've hardly seen any clots despite the circulatory standstill.
We actually looked at, we've looked at extensively at clot formation in DCD in the context of uncontrolled, and really based on our evidence and a lot of evidence coming from other settings, when there's a state of shock and hyperperfusion, you actually have endogenous upregulation of a fibrinolytic system. So the whole clot argument is kind of, it's theoretical. Now there's some thought that maybe there might be clot forming in the recipients, and that might be causing some of the, that potentially could be related to what we see in the liver in terms of ischemic cholangiopathy. But in terms of the donors themselves, there's no evidence really of, I mean, there's issues with cannulas forming clots potentially if there's not enough heparin in a system, but the donors themselves don't clot. In uncontrolled, all have hyperfibrinolysis, and in controlled, I believe that if you were to have extended periods of warm ischemia as well, but that's not been studied.
Okay, Corinne, there's a question.
Yes. In case of incident, you know, in France, NRP is placed in ICU in the room of the patient, so go cold is not possible. And in case of incident, do you include all the time needed to restart the perfusion in the warm ischemic time? And for example, sometimes the ischemic time could be a bit more, and we have to stop the retrieval. It's important to include this time in the asystolic time when you are in an incident, because at the end, we observe 3 primary lung function in France because there is an incident during the NRP, and the time to stop the pump, to find the solution and to restart, this time was not included in the whole asystolic time. And at the end, it's about 40 minutes, and we observe 3 lung function, 3 primary lung function. So it's a recommendation to take into account.
Sarah, I don't know whether you got time for a very quick question for Marta Velia Antonini. If we need to adjust heparin dosing during the run, do we give it to the reservoir if you have one on the circuit? What about other medications, Fiona?
Yes, well, certainly in Edinburgh, our circuit's a hard shell reservoir, and we would, if we had to add any more heparin, we would add it to the reservoir. And I have to say, in all the NRPs that I've done, I have never had to add additional heparin to the circuit. Our protocol would be to add 150 units per kilogram after 90 minutes, but we've never had to do it.
Okay, thank you very much. So moving on to our last talk, it's from Riccardo de Carlis, and he's the head of the Department of General Surgery and Transplantation in Milan, and he has a keen interest in liver preservation, and he's going to have, well, it's a case-based discussion, so he's going to really talk about some cases, and then that's going to be open up for discussion. So I'll hand you over to Riccardo. Thank you.
So thank you, Sarah, for your kind introduction and invitation to moderate this section. This is my disclosure. I have no conflicts of interest, and this is the social media disclosure. This is a case-based discussion, so I'll start by introducing briefly each case, and then I'll move on to discuss with the other speakers the NLP parameters and the DCD characteristics in order to come to the decision of whether to transplant or not the liver. So let's get started with a first case. The donor was a 60-year-old female with a history of hypertension and bipolar disorder, who suffered from cardiac arrest 12 days before and had, as a result of the cardiac arrest, a slight increase in transaminase and creatinine with bilirubin, with a normal level of bilirubin. And you can also see here the warm ischemia time, a total warm ischemia time of 39 minutes with an asystolic period of 31 minutes. You have to consider that we are in Italy, and so we have a 20 minutes standoff period. And shown are here also the NLP parameters, and during a total of 3 hours of perfusion. So let's start the discussion. Corinne and Chris, do you want to comment on that, on the DCD times and the exams during the NRP?
I can start off. If I would just say, certainly without NRP, we would not be particularly enthusiastic about this liver for multiple reasons that you've highlighted there. Functional warm ischemia time would be an exclusion for us. In terms of the NRP parameters that you've mentioned, so 3 hours of NRP, we generally do 2. pH has come up nicely. I wonder if that's been corrected at the beginning. The lactate is coming down, which is reassuring. I don't know if you place a venous clamp there, particularly if there isn't a venous clamp, then that would be reassuring. And the ALT is surprisingly low, given the background that you suggest. So I would say without NRP, we would have significant concerns. With NRP, there are some reassuring characteristics there, but I would certainly discuss it with colleagues before proceeding.
Yes, of course. We placed the clamp in the IVC because there was a combined retrieval with the lungs, so we placed the clamp. Corinne, do you want to comment on this?
In France, we monitor only ILT and IST, and for us, when it's lower than 160, it's okay. And for now, we perform preliminary study about lactate, and we didn't identify a relation between lactate and transaminase kinetics. And for now, we continue to monitor only on the ELT and AST. And for us, the liver is a good quality, and we perform the transplant.
Okay. In Italy, as I said, we usually perform cannulation in the ICU. So at the second hour, we start with the operation. And so you have here some additional data on the liver quality. You have the macroscopic aspect, which is shown here, and the liver biopsy, which is a frozen section, which was available during the procurement, which is a quite good result. And you have also a potential recipient, which was a 65-year-old male with an alcohol-related disease and multifocal HCC with a laboratory MALD of 17 and an estimated cold ischemia time of 5 hours. And we have also to include additional 2 hours because in Italy we have a combined protocol associating NRP and DOP. Amelia, do you want to comment on this, the matching between the donor and the recipient? Do you think that the liver is acceptable for transplantation?
I agree with the comments of our other colleagues. I think the transaminase evolution is reassuring. The lactate coming down, I personally like to see that. I don't know if there's so much evidence for that, but it does show lactate clearance by the liver. Obviously, the warm times are much longer than what we see here, but the recipient seems adequate. And I think the cold ischemia time, obviously, you always perform DHOPE in Italy with these donors. There's probably some need to determine whether that's always necessary or there's certain cases where that can be avoided. But I think the use of DHOPE is obviously helpful as well in your cold. It cuts down your cold time or your total cold ischemia. So I would agree that this looks overall, in spite of the fact that the warm ischemia was prolonged, a decent controlled DCD donor.
Okay, Fiona, do you want to add something on the decision to take this liver or not?
No, I think she's maybe lost her connection there.
Oh, sorry. I asked Fiona if she want to add something.
Hi there, sorry. I think I'd be phoning a friend about this one rather going 50-50. I would be asking some advice from my colleagues. I'm not sure about this one.
Okay.
Can I ask you a question? Are you looking at any bile parameters? Any of the biochemistry during NRP?
On a bile sample, do you?
Yes, like what's done in machine perfusion ex situ.
No, we usually do not perform any analysis on the bile sample, and when we start HOPE, we usually have the decision in mind because HOPE is not used in our protocol as a measure to evaluate the liver, but only for improving the preservation and the result of the transplant. Otherwise, we could think of normothermic machine perfusion, but I really perform it in the DCD setting.
Riccardo, can I ask you a question? You obviously do the biopsies, and I'm aware that in France they also do a biopsy as part of the assessment. We don't, and we very rarely would do one in normal circumstances, let alone on the machine. How much benefit do you think you get from that biopsy? Is it because of your prolonged warm ischemic times you want a bit more information, or why, and how much does it come into your decision-making process?
Thank you very much for this question, because this is a very hot point, because I started always with liver biopsy in the first cases, but liver biopsy, especially in the frozen section, is less informative, and sometimes in distant hospitals you do not have a reliable result. So in the last 2 years I not always perform liver biopsy, because sometimes it's misleading. So I agree with you and your position, not always perform a liver biopsy. So, and this is what we did with this case. We transplanted this liver. We had a good transaminase peak with no kidney injury and no IC after a follow-up of 1 year at our center. So let's move on to the other case, because this is a more challenging and complicated one. The donor was a 63-year-old male with a history of hypertension and cigarette smoking, who suffered from a myocardial infection and cardiac arrest with a risk of 35 minutes and an ICU stay of 6 days with a normal liver function and kidney function, as you can see here. The DCD parameters and the warm ischemia time were quite prolonged, with a total warm ischemia time of 63 minutes and an asystolic time of 42 minutes. So more prolonged than the previous one. And you can see here also the NRP parameters, and I have to admit that I was quite disappointed when I saw them at first, because we have yes, a downward slope in the lactate, but the initial lactate are very high and the transaminase are very, very high over 2 hours, between 2 and 3 hours of perfusion. I'm interested in hearing some thoughts from Amelia and Chris on these parameters. What do you think of them?
So I think that, I mean, this to me looks like what we would see in an uncontrolled setting. Obviously, you can even see some longer warm ischemia periods. The transaminases, according to our rather strict protocol, initially being as high as there, we would probably exclude the liver, though I know you guys have used higher transaminases and have had decent results. It's encouraging that the lactate, again, goes down, at least to me. And the flows look okay. So, I mean, initially, based on what our uncontrolled criteria are the transaminase would exclude it, but maybe we are a little bit conservative in that regard as well.
Chris, do you want to add something?
Yeah, I think this is a really interesting demonstration that of lactate and ALT. And I mean, my understanding would be of lactate correlating with hepatocyte function and ALT correlating with hepatocyte injury and indirectly surrogate as a cholangiocyte injury. And so my impression of this is that this is a liver that, you know, might work. It's clearly functioning here, but there's been significant injury. The risk of acute rejection in the short term and cholangiopathy in the long term would be significant, and that would be the reason for declining it. So I think the ALT and lactate don't necessarily correlate, but they provide complementary important information, certainly from my perspective. I don't know if, Gabby, do you have any?
I think
No.
wait, sorry.
Go on, Amelia.
Biochemistry might be interesting here to me, to know not so much about the function of the liver immediately, but how it's going to work in 3 months, maybe.
I think you're right, and you raised the same point earlier on. We started measuring this, but I think it's too early to know how it will correlate with the clinical outcomes. I mean, for this particular one, I think there are some good information there, but there's some worrying factors. This is probably the one that I would take back and put it on a normothermic machine perfusion for a number of hours just to see how the liver works, because you have a significant level of injury, as you see in the ALT. The ALT on Organox or any machine perfusion will still go up, but you'll get more information about the function of the liver, you know, in terms of lactate, in terms of glucose consumption and so on. And also you can measure the bile and the pH and look at get that extra information that you want to do. So that's probably what I would do here. I would not necessarily throw it in the bin, but maybe bring it back, stick it on the machine and see what it does. We've done this a number of times now, not necessarily with this sort of level of ALT, but more with lactates that were not coming down and, you know, sort of slightly stuttering livers.
Yeah, I perfectly agree with all of you. This is a controlled setting, but the numbers are more similar to the uncontrolled one. And the slope in lactate is quite reassuring. And this is a very good suggestion, the one to take the liver and reevaluate it on the normothermic machine perfusion. This is one of the first cases we have performed in our hospital 5 years ago. And at that time, we had a strict protocol which included only D-hope after normothermic regional perfusion due to a certain fear of a second hit of ischemic hit passing from warm to cold and then from warm to cold again. So we use the D-hope usually in the first cases. You have here some other information, the liver biopsy and the macroscopic aspect of this liver. So the macroscopic aspect can add something to your decision, also toward the selected recipient, which was a 66-year-old male with HBV cirrhosis and a laboratory MAD of 18, which was quite low, but the patient had ascites and an estimated cold ischemia time of 4 hours. So what would you do? What would you do with this data and your decision? Have one of the speakers some additional comment?
Riccardo, it's interesting your picture. Obviously, that's on the machine, but I would have been more also interested in the picture during the procurement and how the liver perfuses once you've gone cold after NRP, because that gives you an idea of that dynamic assessment perfusion sort of on the bench. I think you've added enough information there. I think our criteria, certainly in Edinburgh, with regards to the ALT, we're a bit more liberal. So we're looking at the trend and not necessarily the upper limit. I think we've kind of looking at 500 to 600 upper limit on NRP. If it goes beyond that, it'll go on the machine. So that's what we would do in this situation. And I suspect probably we would transplant it if the numbers are looking good.
Yes, thank you for your comment. Unfortunately, I do not have the photo of this case during the procurement, but I can assure you that the macroscopic aspect was excellent, and this was the main reason why we accepted this liver, and we had a quite impressive good result, because we had a relatively low ILT peak with no kidney injury and an uncomplicated post-operative course with no IC after an overall follow-up of about 5 years. So this is the next and last case, which is quite similar for some aspects to the previous one. A female donor of 61-year-old with a history of hypertension and dyslipidemia, who suffered from an odontoid fracture with a spinal injury without fulfilling the criteria for brain death, after an ICU stay of 15 days, normal liver function and kidney function, with a quite prolonged warm ischemia time of about an hour, at an asystolic period of 40 minutes, and a functional warm ischemia time of 75 minutes. As you can see here, we had during 2 hours of perfusion an upward trend in lactate concentration and an upward trend in transaminase as well. Do you want Fiona to comment on this last case?
Thank you, Riccardo. Yes, well, there's a clearer picture here, I would say. I mean, starting, if we go to the top with the pH, it's struggling to correct, and with an increased trend in the lactate, so that the liver's not clearing lactate, and there is quite a big increase in the ALT. I think we would be declining this liver without question.
Yes. Do some of the speakers use also the SVO2 as a parameter to evaluate the quality of the perfusion?
Yes, we would do. One of our parameters is our SVO2, and we're trying to maintain an SVO2 between 60 and 80% on the pump. Now, you don't have readings there for 0 hours, and is that at 2 hours? I can't see that in there. Yeah, in 2 hours. So I'm presuming then from your bloods that's not read, so it's out with the parameter. So
okay,
I would say, yeah. Okay,
thank you. Amelia, any other comment?
I think here the lactate trend is concerning. The fact that both the lactate's going up and the ALT is going up considerably. I agree that this is a little bit less optimistic about this graft. Yeah. Okay.
Thank you. I perfectly agree with you. And so let's go to the operatory room, and this is the macroscopic aspect. This is a very concerning one with a huge ischemic area in the segment 4, and a liver biopsy, as I said before, which is quite good according to the steatosis, but had evidence of focal necrosis, which is quite unusual, because the frozen section is not always able to detect any ischemic feature related to the recent warm ischemia time. Considering this aspect and the potential recipient, female recipient with HCV cirrhosis and multifocal HCC with the laboratory MALD of 7. What do you do, Amelia?
She can wait. She's got a lab melt of 7. She can wait for a better liver.
Yeah. Any other comment from the audience, from the speakers?
I think this was very clear concerning background, concerning bloods.
Yes.
Mention for the rest of the team that it's often the surprises that crop up with concerning bloods on a background of a less concerning history that's a sort of equal value, I would suggest, of NRP, where we identify the surprisingly poor function like this that avoids disasters as much as the livers that we pick up, that we use, that we wouldn't otherwise have used.
Yes, of course, and exactly what we did. So we discarded this liver. So thank you very much for your attention. Can we move on to the A&Q? Thank you.
Riccardo, before we go there,
Yes.
there's one question from the audience regarding your first case.
Okay.
If you go back to the first case blood results, Luis Rodriguez is asking, what is the meaning of a decreasing lactate and then going up? I think lactate went down to about 5.5 and then went up to about 7 at the 3rd hour.
The first case, this one, huh? Okay.
Yeah.
So some questions about the last increase in lactate. This is the question.
Yes.
Okay. Yes, we had the 3rd hour. We had a quite worse exams in comparison to the other 2 hours. But this was these were the exams performed immediately before cold perfusion, and at this time we had sufficient evidence that the liver was macroscopically good, and there was a previous slope in lactate. The transaminase were stable, so we didn't care so much about this light increase.
Okay, thank you.
Thank you too.
Okay, so we've still got some time for discussion. I have a question really on behalf of probably the audience. So if I'm new to this and want to set up an NRP program, what are the key tips to do that? To one of the panel members, anybody would like to answer? And how do we start to implement this from scratch, really?
Will I kick this one off? Well, I think there's 4 key steps to this, Sarah. First of all, you need a very robust protocol. As you know, we're working to a nationally agreed protocol here in the UK. And then the other 4 key steps is you need to recruit a strong, enthusiastic team. You need to implement some robust education and training. And then you need some steps from implementation. You need competency documents, SOPs, and mentioned the protocol. And then you need to constantly review and evaluate where you are with your program.
Okay, and I mean, in terms of funding, are these? I mean, it'd be good to get a perspective, you know, from France and Italy and Spain in terms of does the hospital pay for this, or is it all through research money, or I mean, who pays to put this in place? Presumably, it's really quite expensive to set up as well.
In France, for two things. First, we have a specific sum for the DCD donation. It's a double sum compared to the DVD one. So coordination and hospital receive money when they perform a DCD procurement. The second point, I have already said that about 80 or 90% of the intensive care unit are already ECMO device, so we have not to pay it, only consumable, and only the surgeon and all the team to perform the NRP. And so with this, with the sum and that we have already the device, is not very costly for us.
Yeah, I mean, I think, you know, if you've got the infrastructure already there, but in the UK, we probably don't. In most hospitals, we have separate retrieval teams. But I think what Gabby's done in Edinburgh is really a lesson to everybody that it can be done, and you can go out there to other hospitals and retrieve with a team of people. which is quite a big task, I think. Gabby, I don't know if you want to comment on that.
I think everything that has been said, it's absolutely accurate. I think you will have the enthusiasts in a new program, but after that, once you've demonstrated the results, and I think throughout the course of this webinar, we've shown that we can get good results in different health systems. I think it needs to be supported at a national level. And what Corinne has achieved in France is absolutely remarkable, that they mandated it. And I think unless we do that, we will not have buy-in. You will always have detractors saying this one's better, this one's easier, and so on. I think there's room for all the perfusion technologies, and Riccardo's experience clearly demonstrates that he can start combining. We've also started combining things to maximize utilization of the organs. But beyond the local team, there needs to be national support for such programs and funding, because otherwise they will not sustain, they will not survive.
Yeah, I mean, I think, touching on sort of Corinne's talk, Amelia's talk, and, coming together and, writing some national guidelines or, international guidelines, because clearly what we do in the UK has significant disadvantages, not being able to do any antemortem interventions. And I think that's probably quite important, isn't it? So, I mean, Gabby, what do you think is the way forward, really? Do you think this, this manuscript's going to have an impact on that in the UK?
Yeah, I mean, I think all the data that we presented and we discussed today, plus what's coming out of the TLJ and other recommendations, and the ILTS, Amelia has steered that group as well, and in ILTS looking at this, will add weight to the argument. It's without a shadow of a doubt that all the data needs to be encouraging there. I think beyond that, it's a bit more tricky at local level how you make this happen, and I'm not quite sure at the moment that we have a clear view. I think there are a number of competing interests that we need to accommodate, and a few more studies that we need to do.
Okay, I mean, an NRP really it's very driven by liver transplantation, but you presented some nice results from the kidney NRP series, and I'm particularly interested in kidney, and I'm just wondering, during NRP you make assessment of liver function and appearance, but do the kidneys get a little bit left behind in that? Can you actually see the kidneys? Can you make an assessment of the function during NRP?
It's very interesting. They stop making urine, certainly in our experience, after about an hour, but they look at like living donor kidneys when you take them out. They look exceptionally well perfused, and I think that's one area where we haven't really designed what are the right criteria for assessing the kidneys in situ, and that's something we can certainly learn from you, because you've got enough experience in ex situ. What can we transfer here to do that? We've just simply gone by the way how they look after being removed. I don't know what everyone else does, and if they got specific criteria for assessing the kidneys.
As far as what we determined in TLJ, it's pretty much just the macroscopic aspect everywhere. Someone mentioned urine output, but then that was kind of poo-pooed by somebody else. So really, it's not. It's how they look for now. That's how people are assessing it right now.
Yeah, I mean, certainly with normothermic kidney perfusion, the appearance is sort of everything as well. I think it's really quite difficult, but it'd be interesting to see as time goes by how things progress, and particularly with all sort of the RNA sequencing and proteinomics and how that's developing really quite rapidly, and whether we can put the two together at some point would be quite interesting, really.
Just to add to that the appearance is, as Gabby said, that is dramatic. The difference from a standard DCD kidney to routinely the kidneys are coming out looking pristine, and I'm not sure whether the evidence that we have so far is underselling the benefit, that because the macroscopic appearance is night and day. So it'll be interesting to see how that pans out, but it could easily become the economic justification for NRP comes from the kidneys rather than the livers in due course.
Okay, well, I don't think there's any further questions, so I will close this webinar, and I would just like to thank all of the panelists and speakers. Really excellent talks, really informative, and I hope that the audience have found that as well. And I'd just like to remind everybody about next week's webinar on the basic principles of machine perfusion. So that's the 23rd of June at 6 o'clock, and we look forward to seeing everybody there. So have a good evening, everybody, and thank you again to all our panelists. Thank you. Oh, and I just have to, before everybody goes, we've got a quick survey there. So if everybody'd like to fill in the poll. So how useful did you find this webinar? And I think we can all vote on that. And we should be able to give you the results in just a minute, I believe. Okay, so we've got 57% have said that they find it extremely useful, 38% useful, and 5% fairly useful, and nobody thought it was unuseful, which is very good news. So I'd like to wish everybody a really good evening and look forward to seeing everybody next week. Thank you.
Thank you.
Thank you.